samples are treated, by all means, please contact us. I think you'll really enjoy that. I do believe your Prime Minister is actually visiting California as I'm visiting Tel Aviv, which is great. And I'm also pleased he is going, I think, to meet the Hollywood celebrities, but he's also meeting in Silicon Valley, where I work, with some of the technology experts, and so that's really great. And then the other thing we have in common, we have so much in common. As you know, I really love coming here every time. But I was just on the beach today. I was with a friend of mine who's at a cardiology meeting at the Hilton, and I saw you had surfers out there on the beach, and the waves were bigger there today in Tel Aviv than they were, I think, on the coast of California. So I learned something today about your surf. That's pretty amazing. I'm going to talk today a little bit about the present, but very much about the future, how we see the future, and why we're excited about it. There is a lot of work to be done. Clearly, I am a big fan, and I know Israel has been at the forefront in thinking about personalized genomics and bringing genomics into clinical practice. I was just in Rome, and we had a meeting there. I don't know whether there were a small number of people from Israel there, yes? But there were people from 29 countries, and I felt very much that was genomics elementary school. We really were, right? But we have to start somewhere, and clearly, many countries, are just now beginning to provide reimbursement and to gain experience. But very much in coming here, I know this is now the advanced course, and it's really a pleasure to be here because there has been so much experience, and you have helped to pioneer our efforts in bringing genomics into the clinical world and into practice. But clearly, the challenge that we face, and I was meeting with Nikki earlier today talking about the future and what we needed to do different. We have a lot of problems, and personalized medicine can be a big part of the solution. Healthcare is soaring, particularly, I know, in the United States. It's just unsustainable, the amount of money that we're spending and the amount of money we're wasting. To give you an idea, there's a slide I sometimes show that shows that in oncology, the average response rate across all of cancers might be on the order now of about 20% or something like that. If we spend $80 billion worldwide on cancer drugs, it means, we're wasting $60 billion a year. It's just a fantastic, issue. And think about what the NCI funding could be, what funding for research could be, if we realized that to take just 10% of that and invest that into good personalized medicine or genomic research, how much money we could save. Clearly, we're making our best efforts in the United States at our first baby step of healthcare reform. And actually, I've learned a lot by traveling around the world and a lot by learning about the healthcare system here. And interestingly, when I flew over on the plane, there were a lot of Israelis on the plane. And I had some fun. When I met people, I just asked them, they did not, I just said, tell me about the healthcare system. What do you think of the quality of care here? And I have to tell you, and I think it's a credit, the people said generally very positive things. That it was really great to hear that. And probably you're not surprised by that. That's really cool. But I think when you ask people that in the United States, you get very variable results. There are certainly some areas we know in the United States where the care is absolutely exceptional, and then there's tremendous variability, and there's a lot of publication. There's tremendous variability in oncotype use in the United States. There are some places that use it just as much as you do. You want to make sure that your patients get the best and don't get less than the best. There are some places in the United States that might use oncotype half as much or a third as much or as a quarter of much because, quote, I already think I know what to do. I think that's the biggest competition is, in fact, still the idea that the standard measures are good enough in many cases. Technology and the cost of technology. I'm going to talk about next-gen sequencing, the amazing things that we can now do, but the policymakers and the payers are skeptical. They have seen so many innovations get used in clinical practice and add to the waste and to the lack of positive health outcomes. A good test is just as good as a good drug, but a bad test that doesn't improve health outcomes is maybe just as bad as a bad drug as well. And so we need to work hard to get that right. So as you can tell, I used to love the work I did before in drug development, and I have now an even greater passion for personalized medicine, for making drugs, for making each of us smarter. I have no doubt that when these cases that we just heard today are presented in 10 years, we're going to be thinking about them, in a much smarter way. I'm going to talk only today about our breast test, but you and your colleagues now have the opportunity to use an Oncotype DX assay for colon cancer, and also the most recent test we made available just in May of this year is a test for prostate cancer. That very big problem of overtreatment of prostate cancer that PSAs has caused us to identify an awful lot of prostate cancer that will never cause a man a problem in their life, where we can tell that man that you're guaranteed to likely die of something else. And yet, even though they know that, at least in the United States, and I think it's common here as well, that over 90% of men often choose aggressive therapy right off the bat, when in fact, with a good test, that might not be necessary. And so we're excited to be able to have Israel participate in that as well. A couple of things. I talked about how quick and great Israel is with regard to genomics. I guess with regard to NICE in the UK, and as you know, NICE is usually not very nice when it comes to new technology, right? It's better late than never, and actually a very nice read if you're interested in their analysis of all the tests that are out there, 70 genes, and is it 46 or 50 genes, or the IHC4 genes, and there are other tests. They're all included in it as well. But they did recommend now for all people in the United Kingdom, not just the patients who have private insurance, that they should have the Oncotype test available. So that's having an effect not only in the UK, but also already Czechoslovakia is coming to public pay, and we expect to see some of the other countries do what Israel did. It was how many years ago? It was a long time ago. Yeah. Yeah. And so now we're, making progress, but there's still a long way to go. And to those of you that travel, and I know you all get out and go to the other meetings, it's important for us to share our experiences and help to educate them. And I think that's one of the reasons why it was great to have Israel present in the meeting at Rome. I'm going to talk very briefly about some new data. You keep up with this, so certainly I think you already know about this. But one is the DCIS score for women with DCIS. I think in particular in the United States, it's already been found to be most useful in patients who are older, who already have quite favorable characteristics, where indeed that with regard to DCIS, you're going to be able to manage that over the course of their lifetime, that other problems are likely to be bigger than the problem of DCIS. It's just scary and something we have to talk about, and the biology that the DCIS score provides. How many of you have used the DCIS score? Yeah. Yeah. Good. Okay, good. So again, that's for those of you, there might be some that said, that was just one study. We'd love to see more data. Actually, back in the lab now, a lot of samples are being processed from a very large cohort. It's going to be about probably 4 or 5 times bigger than the first study with ECOG. The first study with ECOG was a great study. What? Yes? Yeah.
The question should be,
Yes. And so
Now vote again.
don't vote again?
No, you have enough tests, maybe you test it's not.
Because I didn't change. I prefix.
You haven't had the surprise in the two directions.
If I decided upon graduation, DCIS, I will rate education. I don't, and I ignore the test for for the decision to make. I don't ignore the test for my knowledge. I think it's premature to use it as a guide for evaluation.
Okay. Okay. The other thing that might be helpful to you in the new study that's going to be much larger, in the first study, all of the patients only got surgery alone. In the next study, half of the patients will have surgery alone. It won't be randomized, but the other half actually will get treated with radiation so we can also get more information and maybe allow you to be more informed. I have seen other doctors, though, get surprises in both directions. And again, it may take a longer or more tests because 70% of the cases are, as one would expect, usually quite low risk.
My surgeons are here, and I decide upfront what I'm going to do. I'm making this because it's interesting, it's nice to have, it's not, it's really goes by politically demanded. I think it's a little too early to embark on treatment decision with this.
Other comments?
Very, you're myself. I know.
What?
I tell you what I did.
Microphone?
I just sent the couple times I did, I sent the DCIS test before I presented a patient to you, so that you had that information when you decided. Only 2 times.
And I decided,
Oh, you went along with it.
look, we are, one of the cases.
Although you protested that it's too early.
DCIS, multi-center.
Yeah.
And the report was of a low score. Do one of us will not irradiate a multicentric DCIS? 40.
I wouldn't order the test.
You did, but it was ordered. Multifocal, I think it's what, 4 or 5?
Yeah, I love tests, but I think that, in some ways, we're going to be talking about, and you know this, that it's, the other factors are also important, and it sounds like you would have treated her based on the multifocality in her young age, and so would I. Yeah. So with DCIS, again, I think there's an opportunity for more dialogue on this. Certainly, this is one of those diseases, at least in the United States, that still is thought of, and people are very scared of it, and it's leading to overtreatment. Just to give you a number on that, I had the chance recently to give Bernie Fisher a call. I had met him some years ago. And he's in his 90s now. He still comes into work every once in a while. I mean, he's a pretty amazing guy. What? Still amazing. And so he received actually the Lasker Award. Before I called him, I wanted to, I was very nervous, or a little bit nervous, and maybe very nervous, and because he's Bernie Fisher. And in any case, he got the Lasker Award in 1985. And in the speech that was given that introduced him, it said that prior to his studies in terms of lumpectomy versus mastectomy, the rate of mastectomy had been up around 35% in the United States. And with his first studies, the rate declined to 7%. And it was so tragic to call him on the phone now in 2014 in the United States, where the rate of mastectomy is now up near 40% again. So, I think it really highlights, I think that's another aspect of what we need to do is really to do a better job in highlighting, and being brave like Bernie was brave to talk about the disease and our confidence in being able to manage it. And unfortunately, they're the Angelina Jolies, and they get a lot of publicity, and that had a dramatic effect, I know, in the last year in the United States, and I don't know, maybe even all around the world. And so our work in DCIS is very important. I mean, ultimately, we do seek to prevent and eradicate cancer and to treat it earlier and better earlier. Stage 4 disease, we'd obviously not like to see this. In the United States, I think it's around, still about 5% of patients that present de novo with stage 4 disease. The number in Israel, what do you? 6%. So it still occurs here. And this was an investigator study, and probably some of you saw this presentation, and maybe even all of you even already know the results. It was pretty predictable that this is what we would find. Anyone want to say what Dr. King presented at ASCO? What she did is she looked at the question. Ultimately, randomized trials are now being performed and are underway and haven't yet been definitive on the question of what do we do in terms of local therapy? Do we be more aggressive in these patients with local therapy? One thought is, are they all the same? And she was very interested in looking at, did the recurrence score still predict risk, in this case, risk to first progression or overall survival in women that present now at the distant end, not just with node-positive disease, we talked about them earlier, but stage 4. So what she found, it was pretty predictable that the recurrence score biology mattered here as well. And so, this was the curve that she presented. She's going to get longer follow-up with regard to overall survival as well. But this is probably not an underlying surprise. The biology of breast cancer matters long-term. And the recurrence score at the time of looking at the primary captures that. Any comments on this one? What's the current practice here in terms of de novo stage 4, in terms of local treatment is? I know. Yeah. Yeah, go ahead.
I'm saying there were two studies presented in San Antonio which killed local treatment for metastatic disease, except for maybe some very select subgroups, like I think
Right.
one of them was like for single bone metastasis or something like that. And they were different because one of them gave the primary surgery before chemotherapy and then went on to chemotherapy randomized, and the other one were chemotherapy first and then randomized yes or no local therapy.
Yeah.
So you can do it before or after, and both of them showed no difference in survival.
Right.
So
Yeah.
I don't know.
Yeah.
I do it on a very rare
Very-
basis, not on a usual basis. No.
Right. The KI67, the one thing I wanted to make sure I did put up here is I want to, yeah. Yes.
What do I care? What is the time to the first progression?
Ah.
What do I care? I can do it by CDC. Will I start treatment? The question is very much. You receive the argument. What do I care about this test? Why should I perform a test
No,
to inform the patient that she's in a high risk for early breast cancer recurrence and she will die from it?
Yeah. So actually, I'm not showing this actually to say that this is something now that we actually recommend as being typical or common. And I totally concur with the earlier comment that one would want to think about the use of this in any patient, very, very carefully. It was done as an investigator initiated study to look at the underlying biology and the biology question. And so in that regard, it answered a question about the biology, and we supported it. But we didn't do the study in order to think that this would, as one study, change clinical practice. I agree with you.
It's the same as the CTC presented in San Antonio.
Yeah.
That there is no need to hurry up because of CTC positive test.
Yeah.
You just harm the patient.
What Dr. King did wonder, at least her thought was, is that if you could identify a group of patients who had a very good prognosis, then it might make sense to be more aggressive locally to spare her complications that might occur from local progression.
But you know, it's still.
But that was one of the things
we
she was
can
interested
use
in as a
blood
surgeon.
tumor markers in
Yeah.
order to initiate an early treatment. But there is no hint that it helps the patient. Maybe it harms it. We know it from ovarian cancer
Yeah.
with the randomized beautiful study from England.
Yeah.
So why here it would be different?
Yeah, this was looking at a local therapy question was her interest.
Yeah, but the
Yeah.
local therapy was answered
Yes, and that's the
Turkey and India.
So the other thing I wanted to then just highlight quickly is, and I think this was very brave and beautiful work. So some of the very best labs in doing Ki-67 volunteered to look and to compare in a very transparent way. How good are we at actually doing Ki-67? To what degree do we get similar results or not? This resonated with me because in the last century at Genentech, when I was bringing the Hercept test and Herceptin to FDA, we worked with DACO to do the Hercept test, and we began work on that very, very late in the program. Too late is now what I learned. It sort of, in one thing taught me about the importance of diagnostics and thinking about diagnostics early rather than late. But one of the things we did is we took the same slides, unstained slides, and sent them to different laboratories to see how reproducible the results were for the Hercept test. And I looked at the results, both for concordance and reproducibility. I frankly thought they were appallingly terrible. I mean, or at least that they were disappointing. Maybe terrible. Certainly disappointing. Maybe terrible. But in other words, the concordance was 70%, so that 30% of the time the call in terms of HER2 positive versus negative differed. And in terms of the reproducibility from lab to lab, again, it was only about 60 to 70%. FDA at that time had a certain standard for IHC, and interestingly, they were fine with that and approved it based on those criteria. As you know, we've now said, boy, we want and expect much more, which is the right thing. So again, I give this group credit. They took and did the same kind of study. So the six great labs got the same unstained slides and did Ki-67. And on the left, they were locally stained and locally scored. That might lead to the greatest variability, right? Because there might be variability both in staining as well as in reading of the slides. And you can see here, I don't know what is the cutoff that's used here typically? What percent between high and low? What?
San Galen is 30, no?
14, 15, 20 some, I know 20 some places. But notice if the cutoff point was 20, in this expert lab, 100% of the cases would be Ki-67 low. Same cases. And in this lab, 100% of the cases would be Ki-67 high. And interestingly, they did the logical thing was to say, well, maybe that's all variability of staining. If we could stain better, maybe we would agree more often. And here's the result when they were centrally stained and just sent out to be read. This was published in JCO, I think, in September. So I think it's certainly for me, I always had, and I think the scientific issue I had, even with the Hercept test, and I was a big fan of reflex testing, of making sure that we really have quality control for HER2. Lior, you were a bit of a fan of HER2 testing in the early days as well, and making sure that our patients got quality testing. But one of the things I learned about antibodies is they recognize the shape of proteins, and when proteins get hit with formalin during the process of fixation, they change their shape and can either become falsely positive or falsely negatively stained. And that's what leads to very patchy staining. And the difficulty, the reason you're getting a difference here is that it's not that the eyes are that different, but in one case, the pathologist is reading one area of the slide. In another case, they might be reading another area of the slide, and the level of staining might look very different in those different areas. And it will be very difficult to ever get agreement on what area should we look at. So again, I say this, remember I said before, a good test, sometimes the tests we do tend to be just done reflexively, and they get ordered all the time. And it's just, important to recognize that we have to be careful about that. There are other tests out there, and I'm not going to spend time on a bunch of other groups. But again, look at the evidence. Let's make sure that we that prediction really matters, and that we don't settle for the less than the best for our patients. And then one other thing, and this I think would be great to look at in the Israeli experience. We've only done a small registry. Actually, it's amazing. I'm, quite chagrined, and I can tell you that our registry now. How big is the registry in Israel now, Nikki? I mean, or Leo, or how? How big is the registry now in Israel?
We have almost 9,000 cases.
Yeah.
We are working currently on 2,000 cases with a median of 5 years.
Right. So I'm chagrined. The registry work we've just done across a bunch of centers in the United States is a bit less than 200 patients. So it'll be, this is going to be really important to look at this. But at least in those 200 patients, this is some of the data that we presented recently to look at, is the art of medicine, are people thinking about the recurrence score appropriately and integrating it when you get an intermediate score. And you can see here in yellow are the percentage of patients who get chemotherapy, and probably, again, not a surprise, with a score of 18, it's about 29%, and with a score of 30, it's up around 75%. Yep. Oh, yes. The mouse, look at that, thank you, 75%. Oh my gosh, that's so much better. Okay. Yeah.
Some of the American guidelines turned it to be very strange. Your retrospective studies are speaking about 30. 1 to 18, 19 to 30, 31 and a half. Because of the Tyler X, because of some reasons,
Yeah.
everything was moved to the left.
Yeah.
11, 12 to 18, no. 12.
Yeah, I didn't understand that either.
You did not. So, what should the average oncologist without balls use in a patient with 27? According to the retrospective studies you have,
Yeah.
it doesn't have any benefit.
Yeah.
According to the Tyler X, but I'm quoting the television. Okay. Okay, I knew what you were talking about. According to the Tyler X, they were randomized to either, above 25, they all received chemotherapy. What should an average oncologist practicing in Tel Aviv, in New York, in London,
Yeah.
do with the 27 number?
Yeah, and what I suggest on that is to look at the other factors and to integrate those with the recurrence score. The tumor size, the grade, the patient's age, and then a conversation with the patient with regard to their preference, and that varies again from patient to patient. And we did the published work on RSPC, the combination of the recurrence score with tumor size, grade, and age. I'm inclined, I'd love feedback from you. If that makes sense, should we create a tool on the web? Should we make that available? Should we allow, until we get the Taylor X results? I mean, clearly, Taylor X is going to answer this question with evidence much more definitively. But I disagree with you that in the intermediate group that we can say with confidence that there's no benefit of chemotherapy.
Sorry. Your reports with the histograms, 1 to 18 is equal without any chemotherapy.
That
19
we agree.
to 30 shows a detrimental effect of
trend.
1%. Sorry.
Yes.
You have in histograms, the patient are Jewish usually, what I'm treating, or intelligent Russian, and they're asking me, why are you recommending treatment with the histograms showing no benefit
Yeah.
and even a worse prognosis?
Yeah, yeah. So what I'm
Can you
doing is
teach
I'm
me
recommending,
what-
I'm not, I notice I was clear, I didn't recommend treatment. What I did recommend is that an 18 is not the same as a 30, that the other factors can be thought about as affecting, again, how you should think about the risk and the discussion, and that actually the Taylor X study is going to add a lot of value in providing direct evidence to be confident in what to do.
But it will not answer the question of 26 to 31.
Yeah.
Never.
Oh, well, I didn't agree with changing the cutoffs for Taylor X. So in that one, I think we probably agree. I thought that was very confusing.
שולה, אני יכול לצטט?
Yeah,
I've seen a patient of another of my colleagues,
Yeah.
male breast cancer with
Yeah.
an oncotype of 25.
yes.
The other doctors were very keen about, they hesitated about chemo,
Yeah,
and he came to consult me.
Yeah.
He is as a male,
Yeah.
hormone receptor positive, HER2 negative, T1CN0, I think, multifocal, underwent mastectomy. They recommended chemotherapy, and I said, no. 25,
yes.
that was the number.
Yes, yeah.
May I answer?
Yes, sure.
25 translates into 16% chance of recurrence of the study response in spite of 5 years of chemo.
Yeah.
60% is above 10. And we were told that above 10% of the study recurrence, we should consider something about it. Now, the score is, you say the average score between 18 to 30 is 14% recurrence. The 16 is even above the
But Shula,
average.
the problem is not the score. Is the chemotherapy changing the score? The question is not the number. The question is, do this patient benefit from the chemotherapy?
Will it change the score?
What I
Even-
say, if there is a
even it was
benefit
80.
of chemotherapy in
But
the
do
intermediate
we-
range, it's small.
But do we have a evidence? Let us say it was a woman. Do we have an evidence that the chemo will change his outcome with 25?
The prospective retrospective studies suggest, if you look at the B20 plot and the continuous curves, that there might be a small benefit. That is the evidence that we currently have. We could not say with confidence that there was no benefit in that range. Let's take.
That if she was this 1%,
I think
should
I'm
take-
having.
But in order to gain 1%,
Yes.
you should damage 99 patients.
Yeah, I think I'm having the pleasure of what it's like to have a slightly different opinion. And what I would suggest is that we talk about that a little bit later. And can I talk about the future? Is that okay? I will ask your permission. Because otherwise we will not get to some of the new things. Yeah, we won't. Yeah,
Just before you go to
Yeah.
the future,
yeah,
excuse me, no, just a remark because I was checking myself because I just got 2-3 days ago from the cancer registry in Israel the percentage of women that are diagnosed in metastatic stage
Yes.
is 3%.
Yeah.
It was 4%. It's a 2011. It's new data, so it's 3%.
good.
Yeah, yeah. So I
Okay.
wanted to.
that's very good.
Adjust it for the PET-CT use, your numbers are not
That's very
real.
good.
It's not my numbers. It's
Sorry.
the cancer registry
Sorry,
numbers.
cancer registry
It's what you write
should
in the
be dependent.
staging. It's not. I'm just.
Our
I'm
days
it's
on
not.
PET-CT. We are not doing it routinely. Many of my friends are doing it, and the number is higher.
Cancer registry is what the oncologists write.
Okay, so the future actually, I know there has been a lot of So the curve here, what we're able to do now with next generation sequencing, I think all of us never thought we would ever see this in our lifetime. It presents an incredible opportunity, but also a lot of challenges. Our own research group is just an incredibly smart and ambitious group, and they've been working with both the ion torrent machines as well as the Illumina machines for the last 3 years, focusing on next generation. A number of other groups, and we have looked at mutations, but I'm going to tell you about some of the data that we've gotten looking at actually RNA analysis and whole transcriptome profiling, not just of small numbers of genes, and what we've learned thus far, and give you a glimpse into what our products might look like into the future, about what our hopes and dreams are. And I guess I learned here, I went to, what was the museum yesterday? There was a beautiful comment. Herzl, the Herzl Museum in Jerusalem, and he talked about his dreams and about what it takes to make dreams a reality. And it takes will and action. So what have we been doing? I think the first thing to be said, and I always remind myself about this, and I'll show some slides on this later, even though you can get all of this incredible volume of data, will the principles of good medicine and good science go away? And the answer to that is no. Clearly with regard to the new technologies, as we think about it, we're still going to need to focus on delivering what patients, physicians, regulators, and yes, also the payers need, on doing the right thing. Not just getting data and giving people data for data's sake. And tests must be fit for purpose. A PSA test that's very useful in advanced disease that helps to know whether to introduce new therapies. We've learned now that PSA for screening, might, be in that setting might be still of questionable use without an Oncotype DX test to help tell you also about whether it's a bad prostate cancer or a good one. The other thing you all know about is the importance of quality and technology, and how, again, getting the right results with these technologies is not trivial. And again, everybody will say, I can do this myself, because people grow up in the laboratory. I learned this with Herceptin. When we did Herceptin, no one would ever make the case to me, Steve, instead of having Genentech manufacture the Herceptin, we're going to make it at our local hospital or in our local university. No one ever suggested that. But with regard to laboratory assays, and again, I think there are a lot of laboratory assays that can be put in place and can be done with high quality. We have to be very careful. Often, there isn't the money or the resources to do it right. And, that's one of the things that really has made a difference. And then, clearly teamwork and collaboration and sharing data. I'm going to talk a lot about that as being really critical for the future of oncology, as we realize that breast cancer is not just one disease or 3 diseases, but probably it's going to be orphans of orphan diseases that we'll have to learn about from very large data sets. So, how did we learn this? Well, we learned this, the first whole, genome sequencing results. I think now across the world, there are over 1,000 breast cancer genomes. And some of us, I hoped that it was going to be easy, that maybe that there in breast cancer would be 4 driver genes, and that maybe in those 4 driver genes, there would be a small number of mutations, and that we would make advances very quickly. We now know, right, from all of the studies that breast cancer is incredibly complicated. A number that I heard recently, maybe you know the updated number, is 30% of patients might have a whole series of mutations that no one else has. Yikes, that's hard. And this slide has been presented by Ross from Foundation Medicine. This has now been shown by lots of other groups. But there are a couple of genes like P53 and PI3 kinase that are commonly mutated. But again, there is this long tail, a large number of genes where there are only a couple of other patients that actually also have mutations in that gene. As you can tell, I tend to be an optimist, but give me a second for now because I'm going to really be depressing. If we look now at the science of all this, and I like this is actually from the IT world because they've been dealing with large amounts of data for a long time. Having all this data as we collected this at Genomic Health, all of a sudden, instead of having, a bunch of people generating the data and one or two analyzing it, we have like one or two people generating the data and a whole room full of people and machines that are required now to do the bioinformatics and the processing. Science has completely changed in the last 10 or 15 years. Israel actually and a number of technology companies and software companies have been helpful to us in terms of building this infrastructure. So again, it doesn't happen. We don't do it all ourselves and we partner. It's really important. But what does that data feel like? It feels like drinking from a fire hose, and that doesn't feel so good. This is what it sometimes feels like. Being overloaded with data, that's sometimes what it feels like. Have you seen that one before? That one's pretty good. And then this one actually is a nice graph. On the x-axis is how much data you have. And we just went through a little of that tonight. Sometimes when you have more data, sometimes it leads to confusion. It doesn't always lead to light and clarity, unless it's the right data. Actually, I learned this a long time ago. Early on, when I was just starting Genomic Health with Randy Scott and Joff Baker, I went to a talk. A PhD scientist was giving a talk and said, I can give you terabytes of data for your patient. Now, how many of you in the audience know how much a terabyte is? I didn't even really know. But what I did know, it was too much, right? And it reminded me in medical school, we learned how to take a history. And frankly, if you take a history, if you wanted to, you could generate a terabyte of history. You could start out and ask somebody, where were you born? What were your parents' name? What were their parents' name? What were your teachers' names? And you could write all that down and fill up multiple hard drives. But we learned with taking a history, it wasn't how many questions you asked. It was whether you asked the right questions, and more importantly, whether you knew how to listen, whether you knew how to interpret it. And guess what? That's what genomics is going to be like into the future. Some people have said to me in the past, is genomics going to make doctors go away? Are we now going to be treating patients by the numbers? And my answer to that, maybe in 100 years, but again, over the next 10 to 15 years, we're learning, the Philadelphia chromosome abnormality makes a big deal, in CML, makes a big deal in GIST. I can't wait. I'm sure somebody has got a report that sometimes that translocation occurs in breast cancer, and I bet the phenotype is that nothing happens, right? That context really matters. KRAS matters in one way in colon cancer, and the story is a bit different in other tumor types. And so we're going to continue to have breast doctors and colon doctors, and our jobs are not going to go away. We need to, in fact, actually get better at looking at a disease that's going to become more complicated. Do you all agree with me, by the way? Does this make sense? Yeah. So clearly, a big focus of ours and of yours is to look at how we can do research to understand what these alterations mean. And it turns out it's not just mutations, but it's copy number, it's translocations. I believe we should be agnostic. We should use the information that matters. And it's not about proteins better than RNA or RNA is better than DNA. That's a foolish argument to get into that argument. I'm very practical. I think most of us ultimately in our patients are practical. Tell me what works and tell me how I can save my life. and do the right thing. So I'm going to talk a little bit about some of these things. One of the things we did, and it's sort of interesting, is we took some of the same samples that we used to discover the 21 genes, and then using NGS, got 50 million reads for each of those 146 tumor samples. Can't believe that. It's amazing, right? And then looked to see where there are other associations. Could we rediscover the 21 genes? And it turned out we could, so the technology works. But then could we identify any other genes that also predict recurrence? And we found over 1,000 others. It's going to take more cohorts and more studies to determine, could that help us do a better job of prognosis and prediction? As we have some of these larger cohorts, we're going to want to look at that. And we'll see. I don't know the answer yet, but I am interested to see, if we could do better, we want to be the ones to do better. We're not going to do better by just saying that there are two groups of breast cancer, and that breast cancer is that simple. I think everybody, now knows that. The other thing that's interesting is we began to look at fusions now in breast cancer. We talked, actually, remember that secretory breast cancer might have as a fusion one of the events that causes it to arise in the breast. And so we looked at fusion events by doing fancy bioinformatics, right, on each of those 50 million fragments to see whether we could see small pieces that came from one part of the genome unambiguously linked to another part of the genome. That can be done by doing what's called bidirectional sequencing, not just unidirectional sequencing. So it's a bit more sophisticated than the work that's usually done. And so we looked at two cohorts. We actually found 100 fusions in 118 patients. 43% of them predicted an in-frame chimeric protein, which meant that a protein might be made. Now, again, we don't know what that protein does or whether it's important, but we did look at one thing, which was, did we see across those almost 200 plus patients any recurrent fusions? Because maybe those are the ones that might be more biologically important. And we saw 3 recurrent fusions which deserve further study. I will admit to you now, this is a recent observation and we don't know the answer yet, but 2 of these involve some genes that are not very well characterized in breast cancer. And so we have work to do to know whether or not those make a difference or not. But very interestingly, one of the fusions involved the promoter, the 5' part of the estrogen receptor sequence. And interestingly, that ER front end could have been linked to any of 23,000 other genes in the human genome, right? Guess what? The ER fusions in every case were linked to another gene. The bad gene, it was a gene that I and most people have never heard of. Another, what does this mean? ACAP12. And so there's very little written about that protein. Studies are now underway to look at that. If we put that into cell lines, what do we see? Is it oncogenic or not? What does ACAP12 do? But I couldn't wait. As soon as we found this, I called Matt Ellis in St. Louis. And Matt has been doing a lot of work on the TCGA data set. And I said, Matt, have you seen any ER fusions yet? And he said, yes, we saw one. I said, was the fusion partner ACAP12? And he said, yes. So, there's no doubt, this is real. This is, a subtype of breast cancer. It occurs in the primary tumor. So it's important at the time of diagnosis. Again, this is not something that arose out of, the stress of treatment. And we're just going to have larger data sets. Nikki, when we talked earlier, right, about your passion, about the importance of sharing data, of being able to work together, this is so important for the future because we're not going to be able to do this with 100 patients or 1,000 patients. We're going to need much larger cohorts in order to be able to understand this and to work a lot of these things out. One of the other things I know related to estrogen receptor, and again, this is work that came from Israel, right, I love it, is some great work on mutations in the estrogen receptor that actually cause it to be constitutively active. I mean, you know, I can tell you there's a person in the United States who just was so happy to see that result. I don't know whether you know the PhD scientist. Her name is Suzanne Fuqua. She works in Texas. And she wrote 10 years ago, she found, I think it was 1 or 2 cases of an estrogen receptor mutation. She submitted that to multiple journals. I love these stories. And so when I get pushback, when we're being novel and doing innovative things and people hate it, I love hearing these stories, because when Susan Fuqua submitted those papers to the prestigious journals, what did the journals do? They sent her rejection letter after rejection letter. Everyone knows, right, that there aren't, you know, that estrogen receptor mutations aren't important. So I saw her in December, and she was just delighted now to finally have, you know, her work that was done years ago be vindicated. We're going to see that again and again. Last thing I want to talk about is this idea of looking at circulating tumor cells or cell-free DNA in the blood. At Genomic Health, we're looking not only at the time of diagnosis, but ultimately also what happens at recurrence. Can we do a better job of non-invasively? The question was raised earlier. Let's be objective about resistance in breast cancer. Let's be objective about sensitivity. Let's make this more of a science, you know, and incorporate that into our clinical practice. I think there's no doubt, in partnership with you in Israel and with others, that's the future that we want to make happen. And so clearly to do this, we need, you know, ultimately next generation of everything, next generation teamwork, next generation leadership, and next generation collaboration. So thank you very much.
Thank you,
Okay, great,
Steve.
thank you.
Thank you all for
Thank you very
coming.
much.
We have coffee outside.
Thank you very much.